Thank you very much. And the next lecture is will be presented by Aleksei Kashintsev, and the title is HORDEN of a multipronged method of treatment of acute pancreatitis.
Good day. I really appreciate an opportunity to present on the new method we propose for treatment of acute pancreatitis, and then an explanatory study we initiated to evaluate its potential effectiveness. In the first few days of acute pancreatitis, some critical physiological processes like motility of duodenum and jejunum are broken, and as a result, impaired outflow of pancreatic juice with reflux of bile acids and duodenal content, and continued humoral stimulation of exocrine pancreatic function lead to premature enzyme activation and acceleration of autolytic inflammation. We therefore propose a method that may be able to break this pathological vicious circle in the early days of acute pancreatitis. In particular, our method aims to reduce humoral stimulation of pancreas, facilitate the outflow of pancreatic fluid, prevent reflux of bile acids and duodenal content, and simultaneously enable gastrointestinal decompression and provide enteral nutrition. We hope that this method would help prevent progression of acute pancreatitis and development of its complication. In order to implement the method, we use our rather simple catheter, which pictured there. It's placed via a standard endoscopical procedure and can use like a standard feeding or drainage tube. However, it also allows us to block a stomach and create isolated area in the duodenum, in which we can create specific conditions to decompress duodenum or inject specific remedies. We hypothesize the method we use our rather we hypothesize that combined functionality of the catheter provides important benefits such as reduction of small bowel-based inflammatory responses, reduction of pancreatic enzyme synthesis and premature activation, prevention of migration of microbiome and endotoxin and bacterial translocation, and management of intra-abdominal hypertension. In order to test the hypothesis of potential effectiveness of HORDEN in treating acute pancreatitis, in end 2020, we launched an exploratory clinical study. The study is conducted as randomized and stratified, involving both groups of patients with biliary and non-biliary, non-mild form of acute pancreatitis, and comparing the just standard of care versus standard of care plus our method, HORDEN. The study is currently conducted at 7 clinical centers in 5 various cities and intend to enroll around 115 patients suitable for per-protocol analysis. Importantly, the study mandates that HORDEN treatment must be initiated within first 48 hours hospitalization and no more than 96 hours from disease manifestation. The main objective behind inclusion criteria is to only include patients with non-mild form of acute pancreatitis. The main objective behind exclusion criteria is not to include patients with chronic pancreatitis or previous instances of acute pancreatitis with already developed infectious complications, patients who could not tolerate the use of a catheter, or patients with comorbidities that would hinder evaluation of effectiveness of a treatment method. The endpoints we definite for the study aim to address the main question of whether HORDEN is effective at reducing the development of complications of acute pancreatitis and indirectly reducing mortality from this disease. Effect of HORDEN on the economics of treatment acute pancreatitis is also evaluated through assessment of length of stay and length of stay in ICU. At this time, 111 patients have been enrolled in the study and could be included in intention to treat analysis. Unfortunately, 18 of them had to be excluded after randomization due to serious violation of the protocol. Every such patient will be subject of a detailed analysis. For a significant number of patients, not all the data have been verified yet. However, analysis of available data shows a notable trend supporting potential clinical and economical effectiveness of HORDEN in combination with standard of care. In the next few weeks, while continuing the study, we plan to perform more formal interim analysis of the data for the patients who completed the study so far. At the end, I want to say acknowledgements to organizers and to my team and the colleagues who continue to work on this project. And I will be happy to answer the question.
Thank you very much. Very interesting study. It's open for discussion. Any question from the floor? If I understood correctly, so basically the negative pressure that you generate into the tubing, that is the beneficial, this special tool that you are applying in pancreatitis.
Yes, we think that it's very important to recover all these physiological conditions which damage at the beginning. We remodeling this physiological motility to evacuate pancreatic juice, bile acids, and etc.
How much pressure do you apply? That's one of my questions. And then, what are you doing with the side material? I mean, the pancreatic juice and the bile. Do you re-enter into the small bowel, then or just small?
We're organizing about 50 or 70 millimeters of pressure, about 50 or 70 millimeters of, yeah. And of course, we can able to re-inject this bile and pancreatic juice in our control channel in the jejunum directly after aspiration.
Marco?
Yes, it's a very provocative treatment with, which is very intriguing because it potentially affects many mechanisms that might be involved in pancreatitis and severity. And one is, and we were talking about this, the importance of very early intervention. We have some publication about salvage ESFP and salvage placement of pancreatic duct stents to decrease pancreatic duct pressure in order to stop pancreatitis from getting severe. And you could imagine that with this system where you have this low pressure zone surrounding the papilla, that you kind of facilitate the outflow of pancreatic juice very early on, which might then be beneficial for the outcome of pancreatitis. On the other hand, and maybe you can answer that, with regards to the stability of the system, if the balloon would block the papilla, you would get exactly the counter effect. You would worsen. How do you deal with that? How do you secure the position of the two balloons?
Thank you for the question. Of course, only negative pressure is only part of this complex, which we hope that play a positive role on this inflammatory process. But especially when it places in the duodenum, we using endoscopic control, and our upper balloon we placed in the bulb of the duodenum. It's higher than papilla. Especially in the next 2 hours and in the next day, we inject liquid contrast in our canal, which create this negative pressure. And I have a lot of pictures. I can demonstrate that. How it's staying, is it normal position or without it? Of course, another one, we have The second point to protect this is the dynamics of the biochemistry. Biochemistry, it's bile level of bilirubin and level of the amylase.
Okay, thank you very much. If there is no more further question, I think we have to close this session.